Dr. Atul. So we can begin now. Dr. Sajan, we are live. We can begin.
All right. So good morning, everyone. Welcome to you to this sepsis live session. So we are in 8th week of e-course for doctors, and this last week was dedicated to lessons. All of us have a very lively discussions on this platform, on the Telegram platform. I'm sure you must have gone through the course contents, which dealt with the clinical, diagnostic, therapeutic, and preventive aspects of neonatal sepsis. I'm sure there will be some queries. So this session is aimed to highlight the key important points and to take up the queries which are related to the vast field of neonatal sepsis. So this session is divided into two components. One is first half an hour. The faculties will be discussing the key takeaway points for various components of neonatal sepsis, and in last 30 minutes we'll be picking up queries. So all of you are invited to write the queries as we move along, and then we will be taking up the queries one by one after half an hour, after the presentation is over. So I have with me 6 very experienced faculty members who have been interacting with you in the past 1 week. So we have Dr. Nishad Plakar. Dr. Nishad is Associate Professor of Neonatology at Jipar, Pondicherry. We have Dr. Shrikant Kulkarni, who is consultant at Over Hospitals, Bangalore. Dr. Atul Jindal, who is Associate Professor of Pediatrics at AIMS Raipur. Dr. Joginder, who is Assistant Professor at PG Chandigarh. Dr. Mahendra Jain, who is Associate Professor of Neonatology at AIMS Bhopal, and Dr. Sindhu Sivanandan, who is Assistant Professor of Neonatology at Jipar, Pondicherry. So, without wasting any time, I'll be inviting Dr. Nishad to speak on asepsis in the NICU. Nishad sir, please, over to you.
Thank you, Dr. Sajan. Good morning, everybody. So I don't think I need to stress the importance of asepsis in neonatology to this crowd, because we are all from a clinical background, and for the last week we have been having a very active discussion about various aspects of infection and infection control in the NICU. I just wanted to share some perspective, both personal and from a national perspective, where we stand and how relevant this discussion is to our current context, to our work, our current context, and to the improvement of neonatal outcomes. So you all know that, of course, that sepsis is important, but how big a problem is infection in the country? So in India alone, there are just over half a million. In 2019, there were just over 500,000 neonatal deaths in a year. That's just in India alone. And of course, India contributes the largest burden to neonatal deaths in the world. That's approximately 1 neonate dying every minute. And we think a third are due to infection, but probably that number is actually higher, because many deaths that are attributed to prematurity are probably due to infection, as we have shown in some recent studies from India. So we are probably talking about a huge disease burden here and a burden of death. So we are talking about something in the range of 200,000 potentially preventable deaths, because these are due to infection. They are all potentially preventable. So we are talking about an illness where there is a huge burden of mortality, and of course the morbidity that comes from having an infection, the prolonged hospital stay, the costs and all those things, and disability, let's say after meningitis and other problems. So you already know this, but you should also remember that this is one condition that is still one of the biggest issues facing the country, and also one of the rarest in any field of medicine, where you can have so many preventable deaths. where you can actually make a difference. So this is one area where we can make a huge difference. The To share a personal perspective, in 2014, we had a lot of neonatal deaths before that. 2013, 14, we were having a lot of neonatal deaths. And we worked on some quality improvement projects, and gradually the number of deaths came down over a few years. So these are 4 years data, and you are seeing the quarterly data in each quarter, how many babies died in Jipmer. So this is just neonatal death. So it seems to have come down over a couple of years and then stayed down for another couple of years. So you might be wondering, how did this come down? So we did not get any fancy equipment. I think if you look at the next graph, this is bloodstream infections. You can get a hint about what could be the reason. And just to make it extra clear, I'll overlay these two graphs. And you can see the shape of the graphs is almost identical. So this is a real life thing, and we are talking about hundreds of deaths prevented in a year here. So this is something that actually is really, really close to our work, and some area where you can actually make a difference. And one thing you would have noticed in the last few days during the talks is that everything we are talking about, whether it is care in the delivery room or hand hygiene, or the various bundles to prevent infection, they are all inexpensive interventions. So you have the perfect storm here. You have a large disease burden, which actually causes a large number of deaths, the largest number of deaths probably in our field. And you have very cost-effective, very easy to implement interventions that the next speakers also will be discussing. So this is an area where you really, really, really can make a difference. In Jipmer alone, we estimate that around 1,200 fewer babies died in the last 4 years because of infection control practices and other quality improvement projects. So just because the neonatal mortality rate was reduced. But I think the key the difference was in the reduction of infection. So this is one area, it doesn't matter where you're working, this is one area where we can actually make a difference. So please keep this in mind when you listen to the next speakers. And I think I don't have any more slides. So Dr. Sajan, I think I'm done here. Over to you.
Yeah, thank you. Thank you, Dr. Nisha. So definitely quality improvement is the key to future to reduce not only little infections but also can improve outcomes all the areas of neonatology. So we move to Dr. Shrikant, who is going to discuss the key takeaway for sources of sepsis. So Dr. Shrikant, please. The slide visible? Yeah.
Yeah.
Thank you, and you are audible.
So good morning. So we'll be discussing about the source of neonatal infections. So this has already been briefed in our discussion. So just we'll highlight the important points. So before going into the sources, so we should know the what is definition of early onset and late onset sepsis. Most of you know about it. So any signs and symptoms developing within the first 72 hours of birth is early onset, and developing after 72 hours of birth is a late onset infection. And early onset sepsis is predominantly by vertical transmission, and late onset by horizontal transmission. We'll discuss this in the subsequent slides. So coming to the common pathogens which is responsible for neonatal sepsis. So if you take the worldwide incidence and the predominantly from the developing countries, so the early onset sepsis and late onset sepsis, the organism causing these two type of infections are different. So if you take early onset sepsis, group B streptococci and E. coli remains the most common organisms responsible for it. They account for up to 65 to 70% cases of the early onset sepsis. So other organisms are Streptococcus pneumoniae, Enterococcus, and gram-negative bacilli, and Listeria. So whereas late onset sepsis predominantly by coagulase negative staphylococci, that is up to 50% of the cases are due to cons organism. Other causes again Staphylococcus aureus, E. coli, Klebsiella, Serraceae, Acinetobacter, Pseudomonas, etc. So coming to the India, so what are the common organisms responsible for neonatal infection? This is a large study published from the Delhi Neonatal Infection Study Collaboration, that is called the DENIS. So which has shown that so whether it's early onset or late onset sepsis, gram-negative bacilli are the most common organisms responsible for neonatal infection. That is, Acinetobacter was the king with up to 25% of the infections are due to Acinetobacter, followed by Klebsiella and E. coli and cons and Staph aureus. So if you see by distribution of infection in the day wise also, you can see this is Acinetobacter is the most common, followed by Klebsiella and then cons infection. So this is quite in contrast to the Western literature, probably because of more resistant bugs and colonization of these organisms, even in the maternal genital tract, responsible for the early onset sepsis also. So coming to the risk factors, so early onset sepsis, these are the common risk factors leading to the infection in neonates, that is maternal chorioamnitis, defined by maternal fever and two of the following criteria, that is false smelling like maternal tachycardia, uterine tenderness and leukocytosis, prolonged rupture of membrane, prolonged labor, spontaneous onset of premature labor and unclean vaginal examination. Recently, this terminology, maternal chorioamnitis, has been replaced by triple I, that is intrauterine infection or inflammation. So coming to the pathogenesis, how the organism enters the fetus or neonatal bloodstream. So generally with the maternal risk factors, there is a colonization of bacteria in the maternal genital tract, and then the transmission of bacteria to the uterus and amniotic fluid then leads to in utero ingestion or aspiration in utero or at the time of delivery, and then leads to respiratory or gastrointestinal colonization, leading to bacteremia and systemic sepsis. This is known as vertical transmission. So, and some of the cases, especially from the low middle income countries, early onset sepsis has been contributed by horizontal transmission also, especially deliveries occurring outside the hospital settings, in the home or vehicle, or unhygienic birth condition, unhygienic cord care. So poor sepsis precautions during the resuscitation or immediate neonatal care can lead to early onset sepsis with the signs and symptoms developing within the first 72 hours of birth, which is known as again horizontal transmission. But majority are vertical, and few cases of horizontal transmissions are also seen in developing countries for early onset sepsis. Coming to the late onset sepsis, what could be the risk factors and why the babies develop late onset infections? So in the hospitalized settings, again, as stressed by other speakers, that's poor hand hygiene. Poor hand hygiene remains the most important risk for late onset neonatal infection, followed by use of central lines. So either it could be
Dr. Shrikant? Sorry, Dr. Shrikant, can you sum it up in 1 minute or so?
1 minute, yeah. Prolonged central lines, prolonged use of central lines and not following the asepsis during insertion or maintenance, and prolonged ventilation and the one most important is delayed enteral feeding or lack of breastfeeding, which is responsible for late onset infection. In the community settings, prelacteal feeds, poor hygiene, lack of breastfeeding, unhygienic cord care, and delivery outside the hospital settings are responsible for late onset infection. To conclude, the source of infection, majority of early onset sepsis are vertical transmission, and late onset sepsis is due to horizontal transmission. Identifying the source of infection is important to take appropriate preventive measures, and hand hygiene remains the most important preventive measure. Thank you.
Thank you, Dr. Shrikant. I think there were some very, very important messages which you have given. The first is that traditionally EOS and early and late onset neonatal sepsis, they are divided by their spectrum of organisms are different, which are seen in the developed world. early onset more of GBS and late onset more of TONS, etc. But in developing countries, we don't see this distinction in the graph which you have showed you that as even Acinetobacter, the Acinetobacter, Klebsiella and E. coli, they constituted for more than 50% of organisms, not only on in the late onset neonatal sepsis, but also in the early onset sepsis. So very important. Only thing which can differ may be the antibiotic susceptibility, but majority of the time the spectrum does not differ. And so the empirical antibiotic choices also are not very likely to differ in developing countries. And second important message was that these sources can be related to not only the so any procedure which is done on the baby, be it a trivial procedure or be it a major procedure like putting an intravenous line, like putting central line, etc. So all procedures are related to the can lead to introduction of infections and rationalizing all the things. Doing any procedure on the baby. Thank you, Dr. Shrikant. So we'll quickly move to the next speaker, Dr. Atul, who will be speaking to approach on sepsis. Dr. Atul, are you there?
Yes, sir. Thank you very much. I will share my presentation.
Welcome. Yeah. So, Dr. Atul, the slides are visible.
Yes.
Make them full screen.
Yeah, visible, sir.
Yeah, you are audible.
Okay, thank you. So, good morning, everyone. And I'm going to touch upon the various investigations that are being done to diagnose neonatal sepsis. And I would also be discussing on where and in whom to suspect sepsis. So, as the previous speaker, Dr. Shrikant, had already discussed on the various risk factors for sepsis in the early onset sepsis, there are various risk factors where, if present, we should be suspecting sepsis, like preterm premature rupture of membranes, prolonged rupture of membranes for more than 24 hours, maternal fever, if having features of frank chorioamnionitis, foul smelling liquor, other having urinary tract infections or multiple vaginal examinations or unclean vaginal examination. For late onset sepsis, the various risk factors are that the baby is preterm, low birth weight, formula feeding, invasive procedures, receiving any parenteral fluids, there is understaffing of the staff in the unit or overcrowding, and lack of asepsis. The baby is having clinical signs and symptoms of sepsis, we all know, ranging from involving all organ systems like lethargy, overfeeding, full AF, seizures, tachypnea, grunting, rashes, vomiting, feed intolerance, jaundice, purpura, then patient going into shock. So there are various clinical pictures we all know, and it can easily be get mixed up with other problems also. So it is very difficult to sometimes diagnose sepsis, and it is a common differential diagnosis of various other problems in newborns. So how do we investigate patients in whom we suspect sepsis? So we do a classic sepsis screen, which includes the complete blood count, where we look for the total leukocyte count and if there is leukopenia. The absolute neutrophil count is there, which is low. You can look at the various charts based on the weight and gestation. If the immature to total neutrophil ratio is more than 0.2, it is one of the very sensitive markers. CRP is positive, which is defined as more than 10 microgram per ml after 24 hours, or the micro-ASR is more than 15 millimeter in the first hour. If two or more of these screening tests are positive, then we treat infant as patient having sepsis. And the classic septic workup, which includes is the blood culture, which is the gold standard. Whenever we talk about blood culture, it is very important that the volume of blood sent for blood cultures should be adequate. So at least 1 ml of blood should be taken. There are now automated blood culture systems available, which gives the report within 24 hours or 24 to 48 hours. It also gives us the sensitivities. Again, whenever we send blood cultures, it is very important that we send the blood cultures to a freshly put IV line or umbilical catheter or a central line, or a freshly prepared site and then send the samples. We should never use the previously put umbilical lines or central lines to take samples from them and send it for blood cultures, because any growth can be considered as contamination also, and then it becomes difficult whether we are dealing with contamination, the colonization of the lines with the organism, or it is the true culture from the blood. Then, if your cultures, you're clearly suspecting sepsis, you're starting antibiotics, lumbar puncture is must. If possible, urine culture should be sent, but it should be sent only beyond 72 hours where you are suspecting late onset sepsis, because if in early onset sepsis your urine cultures are positive, it generally indicates the heavy growth of organisms in the blood, and which suggests that urine also having those organisms. Endotracheal tube aspirates, if freshly intubated, then these cultures are really useful. Surface cultures, if there are any secretions or pus coming out, and those are important. Chest X-ray and abdominal X-ray when they are indicated. Always remember, when we are working, to prove a case of sepsis, it means almost to get one positive case, which means blood culture positive, you are actually subjecting 10 babies for this amount of work. Again, remember that a single measurement of CRP soon after birth is not a useful marker. Generally, it should be done after 6 to 8 hours. In the first 6 to 12 hours, it can be negative, and the sensitivity improves dramatically if the first determination is done after 6 to 12 hours. Again, if your CRPs are negative, it gives us an indication, okay, our babies are not septic, but positivity can be there in many other conditions also, like birth asphyxia, things like that. Now, procalcitonin is another promising marker, although it does not appear to be reliable as a sole or main diagnostic indicator in newborn sepsis. Now, there are various other tests which are generally for research purposes. There are other cytokines and things like that, which are still in the research mode and not shown to be clearly proven to diagnose, prove or disprove neonatal sepsis. Just speaking on taking both risk factors and symptoms to diagnose early onset sepsis, we get confused and there is always a dilemma. So just trying to simplify. So if the risk factors are absent, or there is one risk factor, two risk factors, or more than two risk factors, and then symptoms, if it is definitely symptomatic, if there are equivocal symptoms or asymptomatic. So based on that, you can send these investigations, which are the standard, that is doing a blood culture, the screen, and depending on the baby is definitely symptomatic, obviously you will do all these things. If the baby is having equivocal symptoms, then if the risk factors are absent, you will just keep on observing them. If they're asymptomatic, routine care is advised. If there is one risk factor, you can send the screen and observe. If the baby is asymptomatic, you just need to observe. If two risk factors or more, then definitely you will do all these things and then start them on antibiotics. So this is the AIMS protocol. If you are suspecting early onset sepsis, two antenatal risk factors present and clinical features are suggestive of sepsis, then you send the screen. If it is negative, you repeat it after 12 hours. Send blood cultures, do lumbar puncture and chest X-ray if they are required, and if this strain is positive, then start antibiotics. If there is foul smelling lacquer or presence of 3 or more than 3 risk factors, then do blood culture, do lumbar puncture and start antibiotics. And if it's late onset sepsis, you will send all investigation and start the antibiotics. So that's all from my side. Thank you.
Yeah, thank you, Dr. Atul. This is a very vast topic and very difficult to sum it up in 5 minutes. But I guess one thing is very clear, that all sepsis parameters, they tend to, the acute phase reactants, including your counts, including CRP, including procalcitonin, they rise immediately after birth, and within first 24-48 hours they remain elevated, and they have a very poor kind of sensitivity, and it is very difficult to differentiate between sepsis and other non-sepsis phenomena, say birth asphyxia, meconium aspiration, temperature related issues, etc. So they are not having a very good positive predictive value, but they have shown to be a very excellent negative predictive value, especially CRP and procalcitonin. So if they are negative, you must think that is possibly not infection. And if you are very much in doubt, you can take help of second CRP or procalcitonin, then decide whether try to stop antibiotics if the laboratory is not supporting you. Try to find an alternative cause for baby symptoms other than sepsis. So the one important thing is blood culture. Always try to take first, try to take blood culture before giving the first dose of antibiotic. That's very important because blood culture is the reference standard, and that should be decide your direction of duration of antibiotics. So first, I think two key takeaway points is that do sepsis screens. The positive predictive value of sepsis screen is very poor. So don't base your and giving antibiotics just because your sepsis screen is positive. Look at the baby. Second, but if your sepsis screen is negative or CRP or procalcitonin is negative, then always think whether I can stop antibiotics or not. Possibly this is not infection, and if you're in doubt, do a second CRP or procalcitonin. And if two are negative, 99% sure that you are not dealing with infection. The first dose of antibiotic before take first dose of antibiotic. So yeah, Doctor. Next, I will invite Dr. Joginder, who will be discussing the principles of antibiotic therapy. Dr. Joginder, please.
Thank you, sir. So, good morning, everyone. So, I will be speaking on principles of antimicrobial policy. Yeah. So, what is an antimicrobial policy? We should have a written statement for every unit that we will give these antibiotics as an empirical treatment for some common infections, or as a prophylactic, like in pre-surgical and post-surgical case, or definitive therapy. If we get an organism, then what should be our definitive therapy? If we have a written explicit statement on these things, then it constitutes an antimicrobial policy. So that policy must include that when we should start antibiotics, means what is the indication, which antibiotic should be started, in how much dose, whether it should be given as bolus or infusion, and how frequently it should be given. The duration should also be well defined, and the route through which it should be given. What are the overall goal? The basic goal of an antibiotic policy is to improve the quality of care and patient outcomes. And at the same time, we want to reduce the collateral damage associated with antibiotic use. Due to excess use, there may be toxicity, so we want to decrease that. We definitely want to limit the emergence and spread of antimicrobial resistance through an holistic antimicrobial policy, and we want to prolong the lifespan of existing antibiotics because it is not frequently we have new antibiotics. At the same time, with a good antimicrobial policy, we aim to reduce healthcare expenses by using lower antimicrobial dose and avoiding the damage caused due to inadvertent use of antibiotics. So, to develop an antibiotic policy for a setup, we need microbiological support because we need blood culture support and antibiogram pattern. We need a good pharmacological support to have an idea about the antimicrobial spectrum, PK/PD of various antibiotics, and the adverse effect associated with antibiotic use. We know support of hospital administrations because it also involves some cost, availability issue, and implementation part. So these things are required before starting an antibiotic policy for a unit. How to develop an antibiotic policy for a given unit? It should be individualized policy for every unit. There cannot be a single policy which acts as a blanket for everyone. So to formulate a policy, typically 6 steps are described by WHO. The first step is to collect data on local microorganism profile and sensitivity pattern. And that data should be collected for fairly long period. It should be at least 6 months. So we have a profile of our culture positive pattern in last 6 months with their sensitivity pattern. Next step is tabulate those sensitivity pattern as per the individual antibiotic. Means how much is the sensitivity against ciprofloxacin, amikacin, meropenem, peptides, colistin. We should tabulate that sensitivity pattern. Third will be tabulate the frequency profile of microorganism. Means what was the overall growth? How many have grown cones? How many grown Klebsiella, E. coli, Acinetobacter? So we should tabulate that. And then do a mix and match to tabulate the sensitivity of antibiotic combination. It means suppose we have an organism, Acinetobacter. So what are the single antibiotic which will act against it? What are the combinations which act best against it? Then we try to choose the first line and second line therapy. So how to choose that which drug will be a first line and which will be a second line? So to choose a drug which will act as first line, first thing to keep in mind, it should be a narrow spectrum drug, because broad spectrum drugs lead to more of antimicrobial resistance. So it should be a narrow spectrum drug, plus it should be sensitive at least against the 2/3 of your microorganism profile. So once we are tabulating, these antibiotics which are covering at least 2/3 of the organism should be considered as a first line, and among them we'll choose the one who are narrow spectrum. Moreover, we should avoid using third generation cephalosporin in this as a first line, because third generation cephalosporin will have a slightly broad spectrum coverage and lead to more of emergence of drug resistance. We generally add an aminoglycoside to have a better synergistic effect. It can be amikacin or gentamicin. So that is how we choose our first line therapy. So once we have chosen our first line therapy, next step is to choose the second line therapy. Second line therapy is a broad spectrum antibiotic, because we want to cover at least 80 to 90% of the organism through this antibiotic. So it is a broad spectrum with 80 to 90% coverage. And if our unit have higher incidence of gram positive, then we tend to add anti-MRSA cover, typically vancomycin. So this is how we choose second line. So once we have developed antibiotic therapy, then we define the duration of therapy. Generally for clinical sepsis, we tend to give antibiotics for 3 to 5 days only. But if we feel it is severe sepsis, like presence of scleroderma or DIC, we may extend it up to 7 days. Pneumonia is typically treated for 5 days. Culture positive sepsis is generally treated for 10 to 14 days. The lower is one for the gram positive one. Meningitis typical duration is 14 to 21 days. If baby develops ventriculitis, it can be extended up to 6 weeks. Important consideration is how to implement it. So once we have formulated the policy, first and foremost thing is we should start antibiotics only when required. It means it should not happen that for any symptom we should start antibiotic. Like TTNB, we know that if it is a typical term baby, bone bisection, X-ray suggestive of TTNB, there's no need to start antibiotic. You can wait and watch. Similarly, there is no role of routine antibiotic in meconium aspiration, birth asphyxia, or well-known viral illnesses or congenital malformations. Second important thing is we should always send blood culture before starting antibiotic, because this is the gold standard and it will guide us about the dose of antibiotic, duration, type, and everything. Third is collect results as early as possible and decide your therapy. We should always respect blood culture report. It should not happen that we are ignoring the reports. If we are sending it with aseptic precautions, we should respect the blood culture report and treat accordingly. Next important aspect is regular audit of the culture pattern, sensitivity pattern, antimicrobial use in unit, and compliance to antibiotic policy. And based on this regular audit, we should update our policy every 6 to 12 monthly. So that's all from my side, sir. This is just a key summary of all the steps of antimicrobial policy.
Thank you, Dr. Joginder. I think that is very concise and comprehensive as well. At the same time, so basically, what you have two key takeaways, that your antibiotic policy, empirical antibiotic policy, should based on your own kind of organisms and their susceptibility profile. So you should have an audit of your past data and try to formulate policies. And your first spectrum, I think few of the participants might get confused with the narrow spectrum of the individual drugs and 60 to 65% coverage with the combination of drugs. Basically, what Dr. Joginder wanted to highlight, individual drugs included in the empirical policy should not be broad spectrum as carbapenems, etc. They should have a narrow spectrum like aminoglycoside. Combination of penicillin can be a very first line empirical therapy. Individually, they are having a narrow spectrum, but as a combination, they can cover 60 to 65% of. So, thank you, Dr. Joginder. I think we can move to the next one. I invite Dr. Mahendra to talk on principles of prevention of sepsis. Dr. Mahendra?
Yes, sir. Actually, PowerPoint is loading.
Okay. While the PowerPoint is being loaded, Dr. Joginder, can we questions related to your the participants? Can you unmute yourself? Yeah, Dr. Joginder, they have asked about aminoglycosides used for gram positive. Sometimes the blood culture report shows aminoglycosides for susceptibility for gram positive bugs. So can we give aminoglycosides or other, amikacin and gentamicin, etc., for gram positive infections?
Sir, actually, aminoglycosides are generally not active against the gram positive except the staph. But since if we have get culture positive, we have to give 10 to 14 days. Typically for 10 days at least for MRSA. And aminoglycosides should be avoided beyond a duration of 7 days. Ideally, they should be confined in first 3 to 5 days. But we should not be used as a therapy.
Thank you, Dr. Joginder. I think your voice was breaking in between, so I will summarize that yes, it has got aminoglycosides that do have some anti-staphylococcal activity, but they don't generally cover other broad spectrum of gram-positive organisms. And we have a constraint of giving aminoglycosides beyond 5 to 7 days because of the toxicities, especially nephrotoxicity and ototoxicity associated. Basically, we should keep them in mind and not use aminoglycosides for beyond anti-staphylococcal. And anti-staphylococcal also, it's not it has got some cover, but does not mean that it is a primary anti-staphylococcal. So when you have staphylococcus identified, try to use proper anti-staphylococcal drugs, for example cloxacillin, etc. So, but certainly if you want to combine, you can have synergistic activity with cloxacillin and amikacin. Okay, so yeah, Mahendra, are you ready? Dr. Mahendra? Dr. Mahendra? Yes, Dr. Mahendra is having some.
Yes, sir. Actually, this file is, they have written this, we can't share this file because this file type is not supported by the file sharing.
Okay, so I think we can take up a few more questions which are there in the chat box in the meanwhile, while you sort these issues out. So, Dr. Atul. Hello, Dr. Atul.
Yes, sir. I'm good.
Yeah, so there was question in relation to the cutoffs of CRP and cutoffs of procalcitonin. So basically, CRP, you showed that 10 microgram per ml, kind of a cutoff, which will generally the laboratory gives in milligram per liter. So which will equivalent to 10 milligram per liter. That is the kind of cutoff which is usually used. But people are asking about 6 and 8 and 12, etc. So I'm sure, I suspect they are doing a semi-quantitative kind of a thing. So can you just clarify this part to them?
Yes, sir. So whenever we do CRPs, ideally we should be doing the quantitative CRPs, and the cutoffs which I have told is for the quantitative CRPs. So if you are doing a semi-quantitative CRP where you do it in dilution, that is 1:1 or 1:2, so more than 1:2 dilution should be considered as equivalent to 12 milligram per deciliter. You can take, so anything more than 10 milligram per deciliter should be taken as positive CRP. So 1:1 dilution or 6 or 8 is just positive, that does not carry any. So to be really clinically significant and to be taken into the picture for diagnosis of sepsis, it should be really positive, and for that at least 1:2 or more than 10 milligram per deciliter should be taken as the cutoff.
Yeah, absolutely. I think that is an important point, that you should take more than 10 milligram per deciliter. And remember that CRP, because it's a non-specific inflammatory marker, so it will also be elevated in other non-infectious phenomena. For example, simply after the stress process of birth, within first 24 to 48 hours of life, the CRPs will be elevated. It can happen with birth after birth asphyxia, after meconium aspiration syndrome, after going through hyperthermia because of any reason. So you can have falsely elevation of CRP. So CRP has a very poor positive predictive value. With positive predictive value means if you 100 babies are symptomatic and you do CRP in them, the real infections will be there not more than in 10 to 20% of the cases. So for early onset neonatal sepsis, it is only 10% as the positive predictive value, but it has got more than 90% negative predictive value. So that is actually the kind of a thing which I was trying to get at. So if you have a positive CRP, just try to think whether it is a real infection or not. But it is a negative CRP, and it does mean that possibly you are not dealing with infection. And the cutoff part is if you are dealing with a laboratory, rate nephelometry or turbidometry, it's 10 milligram per liter. And if you are doing semi-quantitative, it is 1:2 dilution. There are always issues related to the dilution process and a kind of doing semi-quantitative methodology, but that's a talk for some other. So, Dr. Atul, while you are there, what about procalcitonin? People are very curious about knowing procalcitonin cutoffs. So, anything to talk on procalcitonin?
Sir, again, same as CRP. So it has got almost like 70% sensitivity or almost around 90% of specificity beyond 2 microgram per ml. So labs gives in various values. So more than 2 is taken to be as definitely significant. And again, as with CRP, there can be false positivity with procalcitonin as well. So serial values has definitely got a role in deciding your looking at the course of the management, the course of the baby in the disease process. So serial CRPs or serial procalcitonin values definitely have a role, but as a point of care to diagnose or to refute the diagnosis, again, they have their own challenges.
I think that's very important message that procalcitonin is also a kind of acute phase reactant. So it rises earlier than CRP, while CRP reaches at peak at 19 to 20 hours. The procalcitonin rises very early within first 6 hours. Basically, the cutoff of procalcitonin are for late onset neonatal sepsis and for early onset neonatal sepsis is different. Late onset neonatal sepsis, a cutoff of 2 microgram. About the units, but a cutoff of 2 is important. But for early onset neonatal sepsis, I think there are nomograms available. They are published in Clinical Chemica Acta 2011 by Keisa et al. CHEISA, Keisa et al. So you can follow those nomograms and you can see that you will find that there are a lot of falsely elevated procalcitonin in the first 48 hours to 72 hours of life. So try to follow nomograms in the first 72 hours of life, and after that a cutoff of 2 will be reasonable. But some people, people have given sensitivities and specificities at various levels at 2 or 0.6, 1 and 2. So the sensitivity of and specificity of roughly 80% is achieved over cutoff of 2.
The units are microgram per liter.
Yeah, microgram per liter. Thank you. So, Dr. Mahendra, are you ready now, or can we take up a little more questions?
Sir, Dr. Pratima is I have mailed her, and she is now going to.
Yeah, I'll be sure.
Okay, Dr. Nishad, are you there? Dr. Nishad, are you there?
I'm here. Just a moment.
Yeah, okay. So there was a question in relation to the catheter tip culture sensitivity for catheter, CLSBI. So should catheter tip should be sent, or should we?
No, we don't send the catheter tip for culture anymore. There is an entity called catheter-related bloodstream infection, for which we often also take culture through the catheter, a blood culture through the catheter along with the peripheral blood culture. But that's currently only done for research purposes. So for practical purposes, no catheter tip culture or culture through the catheter.
Yeah, thank you, Dr. Nishad. Thank you very much. So, yeah, I think we are ready with the slides. So, Dr. Mahendra, can you make it a full screen?
No, sir, from my side, it's not possible.
Yeah, that's okay. Are you able to see the full screen?
Yeah.
Yeah, I think you can then proceed with the. You are audible, and you can proceed. You can say just next. I think Dr. Pratima will be changing the slides.
Okay. So,
Thank you.
already that most of the things are discussed now. It's principle basically that we discuss and now summarize. I am summarizing all your slides. So follow the microbe in its journey from hospital environment to bloodstream of the neonates. This is the basic principle to prevent hospital-related infection and also including in the newborn also. Next slide. Next slide, please, Dr. Pratima. Okay, so we have to prevent entry of microbes into the NICU, then their proliferation, and then baby-to-baby spread of infections, and decrease entry in microbes into the body, decrease susceptibility of the baby by improving immunity, and better administrative practice are important. So for that ensure clean delivery room environment, this is the very important because that the not only the NICU but also that the delivery rooms should be visually clean and that the proper safe disposable. Care of the equipments is equally important there, and the training of this require training of the staff for this. Then ensure clean immediate environment of NICU means the corridor of NICU is also need to be clean or sterilized, like do the things all the like the take the precautions like NICU, and there should be the restricted entry and there should be the designated waiting area should be there, and there the limit that the parents and the other go, there should be the visiting time should be there. And the third is the entry restricted into the NICU, like the healthcare worker or the other related staff, they should be take proper precautions and gowning and all these things are important, and there should be the restricted NICU entry. Hand washing before entering the NICU already that we have a very good video already discussed. Gowning slippers are very important. And air changes are very important now that the few units are having, other are not, like there should be the 12 cycles air changes and there should be the filter should be there to like the 0.5 microbes, they should be clean its particles. Next slide. So now the preventing proliferation and infection in ICU, good housekeeping practices should be there, and equally important the decontamination of the equipments. And we have discussed all how to do this. Now preventing baby to baby spread of infection, there should not be overcrowding. Nurse patient ratio is very important, like a multi-drug resistant infection is there, then 1:1 ratio should be there. Hand washing policy, use of plenty of disposable laminar flow system, and one of the important is the prohibiting stock solution for flushing IV fluids, and handling fomites like separate stethoscope and that the thermometer, measuring tape, all the possible that the fomites that handling is very carefully in an ICU. Next slide. Now the decreased entry of microbes into the baby, like the cord care, skin is very delicate. We have to care with all the precautions. Procedure during precaution during procedure already we discussed in the previous PowerPoint. Handling invasive line, handling parental drug and nutrition, intubations, and that the ET suction we have to take precautions, and early discharge of the baby. Now decrease susceptibility of baby, like use breastfeeding, kangaroo care, prevent malnutrition. That there should be the mother-based neonatal care. If there is possible, then we should do it. Next slide. Better administrative practice is very important. Already we have discussed about the blood culture policy, their environmental surveillance should be there, and rational antibiotic policy, infection control protocols, and there's a continuous plan for epidemics, and structural orientation, new team members, like initially 4-5 days, we have to give proper orientation, motivating up the staff, those are doing good practice, and authorizing the NICU sister to follow the compliance and the policy. Next slide. So this is about the principles, and thank you.
Thank you, Dr. Mahendra. I think that there are some key important messages which are hidden. I think it is mothers versus others. Mothers have usually unrestricted access 24/7 inside the NICUs, but other members, they should be having a limited, interaction, and they should not be having a free thoroughfare. And although this is the participatory and kind of things are changing, but as of now, the mothers are having an unrestricted access. They should come, they should do KMC, they should visit the baby. So, second is in relation to the prevention of sepsis. We all know that the sepsis is entering through various routes. You can enter through enteral nutrition, you can enter through intravenous cannulation, through procedures like, for example, blood sugar monitoring, for example, as trivial procedure as doing weight, because you are getting colonized, you are removing things for doing weight, but attachments for doing weight, in case you don't have an inline weight, or it can be introduced by various invasive procedures. So we should rationalize all the procedures, but most importantly, at every point of time, we should judge whether this baby requires continuation of IV fluids, continuation of cannula, continuation of antibiotics. I think these three things are important. Every visit, you should ask yourself a question, whether this baby requires one more dose of antibiotic, whether this baby requires continuation of IV fluids, or can I shift this baby to enteral feeds? And third is that whether the cannula, whether you should take out these are, I think, if you do this, you will be doing a great service to the baby. So we'll quickly go to the next presenter, Dr. Sindhu, who is going to brief on bundle care. Dr. Sindhu, are you there?
Yes, sir.
Yeah, so I think we are very close to the COVID-95, so maybe you can just give one or two slides and give the brief points.
Sure, sir.
Thank you.
So I'll talk about bundles and implementation. One important thing that we note is hospital-acquired infections are more common in low-middle income countries compared to high-income settings. So most common underlying cause hospital-acquired infection can follow in one of these four categories: central line-associated bloodstream infection, ventilator-associated pneumonia, catheter-associated urinary tract infection, and surgical site infection. Among these, the central line-associated bloodstream infection is very, very common. They are associated with high mortality and increased length of stay. So, how can we prevent these hospital-acquired infection? So, we need to implement low-cost bundled interventions using quality improvement approaches. So, how our outcome here is hospital-acquired infection. This is what we want to try to prevent. So, in order to address this, it is very essential that we address these two things: the structure and the processes. Structure would refer to the existing hospital structure, which can reduce the likelihood of harm. The processes refer to the various processes that we are supposed to do. An example of a structure would be to have adequate staffing in level 3 and level 2 NICU, having regular surveillance of infection, which include the clinical hospital-acquired infection as well as environmental surveillance, vaccination of healthcare workers, having appropriate hospital visitation policies, and avoidance of overcrowding. So this has to be addressed. Now let's look at certain bundle of care interventions. What are these bundles? So bundles are basically a set of evidence-based interventions These evidence-based interventions ideally should come from good evidence, which are level 1 evidence from randomized controlled trials. And these have to be implemented together for better outcomes. Implementation of bundle of each one of the bundle component is very essential, and it improves outcome compared to isolated implementation of individual measures. So when we talk about bundle, it is all or none phenomenon. That is, you implement each of the bundle components together. And the second important thing is the bundle is not an universal bundle. It has to be adapted to the local setting. So let me give you an example. For example, this central line associated bloodstream infection, these are the 3 portals of entry. So the entry can be the patient's own skin endogenous flora, or from the hands of healthcare providers, or contaminated the skin, lack of disinfection. So 60 to 70% is because of this. So if we have to address this. Then the second common cause, 10 to 20%, is due to contamination of the hub. Very rarely it is because of contaminated intravenous fluids. So an example of a Class C bundle would include having hand hygiene, use of full barrier precautions during central line insertion, adequate skin disinfection, use of alcohol or chlorhexidine based disinfectant, avoiding a femoral site because that site is likely to be more contaminated, removing the unnecessary catheters, having a checklist, and promotion of safety culture. For example, somebody does not follow these procedures during insertion, you stop him there, advise him to do full asepsis and then insert this bundle. So this is an example of a Class C insertion bundle. This I want to highlight again. This is aseptic non-touch technique. So there are 2 important things that we need to note. One is key part and the key site. What are those key parts? These are key parts are those which are likely to come into patient's bloodstream or mucosa, catheter tip, syringe tip, the needle. These are never to be touched by the hand, even with sterile hand. These are never to be touched. Key parts are those where there is an access is there. For example, the bottle tip, the hubs, or denuded skin. So these directed touching of key parts and key sites should be protected during aseptic non-touch technique. So this is the final slide. This is another bundle. An example is VAP bundle. So we know that ventilated neonates are at higher risk for ventilated. The portal of entry can be contaminated hands, the contaminated ventilator circuit, or aspiration of contaminated oral secretions. So here we can implement a bundle of intervention. For example, elevating the head of the baby 30 to 45 degrees so that own aspiration of oral secretions does not take place. Performance of hand hygiene. When you suction endotracheal tube, make sure that you are using sterile precautions. Have a unit policy of when to intubate, when to extubate, and when to suction. There is no indication for routine change of ventilator circuit. Maintain that the oral hygiene is proper, and every day evaluate whether the baby is ready to be extubated from the ventilator. Do not use routine sedation, and if there is a need for sedation, consider sedation vacation. So these are bundles. Bundles finally are low-cost interventions, but they have to be implemented together. Thank you, sir.
Thank you, Dr. Sindhu. I think that's a very broad kind of 3 major bundles you have condensed in a very short time. So while you are there, can you just tell about the surveillance also? So people have asked about NICU microbiological surveillance. Should we do, and what should be the frequency of microbiological surveillance?
So most high-income countries do regular surveillance. The surveillance can be of clinical surveillance and environmental surveillance. Clinical surveillance would include what is the incidence of hospital-acquired infection, what is the incidence of culture-positive sepsis, Class C, UTI, catheter-related UTI, what is the antibiotic resistance. Those are clinical surveillance that we do. Second is environmental surveillance. Environmental surveillance refers to this growth of bacteria from inanimate objects, for it can be surface of a phototherapy machine, baby's crib, the mother's feeding utensil, it can be from the stethoscope, etc. From low middle income settings, we do not have a regular or a policy regarding environmental surveillance. Although there is if we in the environment, if we have multi-drug resistant organisms, staphylococci or MDR organisms, then there is a higher risk for hospital-acquired infection. But there is no cause and effect to this thing. So how regularly it has to be done, environmental surveillance is usually determined by hospital infection control committee.
Yeah, I think routine surface cultures, if you take the surface are going to be colonized, they are not going to be routinely helpful. But you have once you have some surveillance, once you have something, if there is any increase in the risk in the incidence of infection, then it is definitely going to be helpful, and to identify the source from where it is going. So. Sorry, from where the infection is coming. It could be because of the, something like typhoid Mary. It could be because of the overhead tank which is not being cleaned. It could be some bottle from which you are taking chital forceps or something like that. It could be anything from which the infection is coming. Basically, the cultures, the surveillance cultures will be helpful in those situations. So, Dr. Sindhu is pointers of epidemic. So, when we should consider an epidemic which is happening.
So one is an unusual organism, even a single unusual organism or two or more occurring in a row. Or if we have a normal frequency, but we are seeing a new or a higher frequency of culture positive organism, that is when we think about an epidemic.
Excellent. So basically, there are ways to go about it. I think it depends upon what kind of a symptom you are, or what kind of a the disease you are referring to as an epidemic. For example, there could be a single episode of diarrhea should be taken as an onset of an epidemic. A single episode of multi-drug or extremely drug-resistant Acinetobacter should be an point of onset of investigations as an but in circumstances you can actually go very scientifically if you're plotting runtime charts. So anything which is going more than 95% of the confidence limits, that is an onset of epidemic, or more than 20% above the baseline frequency, that is associated. That is an kind of a bigger point for investigation. But we should be careful. Thank you, all the faculty members. We have some questions which have been posted. Some of the questions we have answered, but some of the questions we can take. So, Nishad sir,
sir, he just left. He had some work.
Okay. So, Dr. Sindhu, can you just, there are a couple of questions in relation to soiled umbilical cord. How should the soiled umbilical cord be cleaned? And if a baby is coming with the foul-smelling umbilical cord, so what kind of, how should we approach this? Can you take up?
Sure, sir. So dry cord care is advised. Clean with clean water. Keep it dry. And if it is soiled with feces or something, you can use a mild soap and water and clean the umbilical cord. Second, when the umbilical cord tends to fall, you might have certain discharge and even somewhat a smelly umbilical cord. I would look for other symptoms before labeling as omphalitis or umbilical cord infection, which would include redness, tenderness, induration, fever, or any other symptoms in the baby.
Yeah, thank you. So basically, don't just look at the discharge and decide. also look whether it is intubated, whether there is a tenderness, whether there is any, the temperature is elevated. So all these things should be looked at. But if the baby is having, and so also look at the systemically how the baby is behaving. So in a well feeding, well happy-go-lucky, kicking around baby with a slight of discharge, with otherwise umbilicus cord, the skin of the umbilicus, which is equivalent to the skin otherwise, the other parts of the body, tenderness. It is just a umbilical cord is falling, and this is just a normal type of physiological process. But in a baby who is coming from outside, who is sick looking and who is having all these signs which Dr. Sanjeev has pointed, you are dealing with umbilical sepsis. So you should clean these with the spirit swab and systemically treat this baby for neonatal sepsis. So yes, we have a couple of, we can take some questions. It's already 10:08. We have already beyond the hour, but I think this is an important topic. Some things we can take up. Dr. Atul, are you there?
Yes, sir.
Yeah. So can you, the people have asked whether CSF and blood culture can be done at the same time. Should they be done at the same time? Or
Sir, if we are taking blood cultures and we are starting anybody on antibiotics, and we give antibiotics, it's mandatory to do a lumbar puncture to rule out meningitis. The point is, for doing a lumbar puncture, baby should be hemodynamically stable. So that is the most important point. The baby, lumbar puncture should be deferred till the baby is stable. So that can wait, but yes, blood culture should be sent before starting of antibiotics, so that we can.
Absolutely. I think spot on. So before the first dose of antibiotics, blood culture must be drawn. But as close to that possible, you should draw a CSF, because remember that once you institute antibiotic, the first thing to go is microbiological aspects of the CSF becomes sterile. So within few hours, the CSF becomes sterile, and the next is to stabilize is the cytology or cells. The proportion of cells the number of cells they are going to be decreased in next 24 hours or so. And the proportion is going to change from polymorphonuclear leukocytosis to more of lymphocytic response. And last to change is the biochemistry, which takes a few more days, maybe 3 to 4 days. So there is, you should do it as early as possible, because as you go farther away from the point of starting of antibiotics and do CSF later on, the chances of CSF picking up a positive CSF decrease. So thank you. And Dr. Atul, they have also inquired about the leukocytes. How should interpret the leukocytes cutoff?
So as I discussed in the slides also, that we should follow the charts, and those charts would give us, they are above the normal cutoffs, so these vary according to the age and gestation age. There are Monroe's and Kelly's charts which are available, and one should follow those charts to see whether there is leukocytosis or leukopenia. However, various studies have shown that no blood count derived indices actually have that adequate sensitivity to rule out a role in neonatal sepsis. So again, it's the battery of tests, and still we are lacking that triage test, which would definitely give us the answer. So leukopenia definitely has higher and better sensitivity as compared to leukocytosis. Shown in
thank you, Dr. Atul. So thank you. I think the message is well clear that there is no single cutoff. One thing is important to understand in relation to the leukocyte count is that in older age groups, we see more of a leukocytosis as a marker of infection. But in neonates, leukopenia is more of an indicator of infection. So anything less than 5,000 and any ANC value of less than say 1,700 or so, that is kind of a suggestive of you, that takes you more towards sepsis rather than leukocytosis. Many a times in sick neonates, the leukocyte counts of 20,000 even up to 25,000 can be perfectly normal if you're not dealing with an absolute neutrophilic leukocytosis. So those kind of values can be easily seen in neonatal sepsis. So you need not jump on the leukocyte count and see whether 20,000 is there. So I'm dealing with sepsis. No, look at the baby. try to see whether baby is displaying you the signs and symptoms of infection, and higher counts, maybe combine them, combine these leukocyte counts with other data points, for example, CRP or Procal, etc., to make your diagnosis of sepsis, rather than simply blindly following a single leukocyte count with all other things normal does not indicate that we are dealing with sepsis. Thank you, Dr. Atul. And in relation to, there was also a question in relation to the contraindication of LP. So I guess that is more, Dr. Atul has clarified. So hemodynamic instability is one. But if bleeding tendencies are there, then also there is a contraindication. So you should get, if there is a bleeding tendency, you should stabilize, give vitamin K, check platelet count, any value less than 50,000, you should give platelet counts and stabilize, and then do the LP. And third is if you have other contraindication, maybe the local site infections, or whether you are having some anatomical malfunction, for example. So all those kind of a thing are relative contraindications. In older age group, high raised ICP is one of the contraindications. So luckily in neonates, we don't have such raised ICP is not a bigger concern because of the sutures which are dilated. But in a baby who is displaying you frank signs of raised ICP, I think we should also avoid. Generally, raised ICP is not a contraindication as far as neonates is concerned. Nevertheless, I don't mean that you should not look for it. Look for it. If you are having signs of raised ICP, then you should avoid doing the rubber puncture. Yeah, so people have also asked about endotracheal tube cultures. So endotracheal tube cultures, as has been highlighted during the presentation, the endotracheal tube culture should be done not with the preferably with the freshly put tubes. So once you have put tubes, you instill. It's kind of a mini ball which is sent. Instill 1 to 2 cc saline, and while the feeding tube is there in position, wait for a minute or so, aspirate it and send it for culture. But if you have a tube which is placed for a longer duration, the chances of colonizations are high. So remember, these are majority of them, they are going to be colonization. So what is the role? The role of endotracheal tube cultures comes once you have all other investigations are negative and your X-ray is showing a frank pneumonia. So in that place, you can have you can get some idea from the endotracheal tube culture. But you must always differentiate the colonizations, which is there in maximum chances, maximum proportion of the endotracheal tube cultures, not done carefully, and you will be getting a more of colonization rather than real infections. So, if you, but in case the baby is on high frequency setting, so very sick, you are not, you have to send endotracheal tube culture. So mention that this is an old tube, it might be colonization. But then in that case, if you are forced to send, in those situations, discard the first, first 1 ml saline, instill 1 ml saline, wait, discard, aspirate, discard, and then take the second sample and send it for culture. And interpret it very carefully. It does not mean, I'm again saying it does not mean that you are dealing with, that is a source of movement. Yeah, so I think majority of the questions we have taken. So if anybody wants to ask any question directly, we can take 1 or 2 questions, and then I think we are done. It's already 10:60. Would you like to say something?
No, sir. It was a very informative session. None of the participants are actually logged in with us in the Cisco, so they are interacting on the YouTube only, sir. Sir, 1 or 2 questions are left, like how long should we wait before shifting to the second line antibiotics?
Yeah, I think that is an important point. Dr. Joginder, are you there?
Yeah, Dr. Joginder.
Yes, sir.
Yeah, so the question is in relation to how much time after starting antibiotic, we are on the first line antibiotics. So how much time we should wait before going to the second line antibiotic? What should be the trigger point to go to the second line?
Right, sir. So generally we want to change to second line only when we feel that baby is not responding or baby is worsening, and we have not grown anything in the culture. Either it is trial or baby has worsened very quickly. So as we must know that once we have given antibiotic, it takes some time to work. So at least 24 hours antibiotic takes to work. So I don't think there is any point in changing before that, unless until we know that baby has scleroderma, DIC, and we know the commonest bug which is causing that thing. Otherwise, we generally wait for 24 to 48 hours, and then only we tend to change to the second line.
I'm sorry for the interruption, Dr. Joginder. Please carry on. I'm sorry.
Yeah. So I was saying that generally we wait for 24 to 48 hours till the time we have given enough time to the first line antibiotic to work, unless until baby has worsened so severely to develop scleroderma, shock, DIC, and we feel that the commonest bug is different and which is not being covered with the first line. Like suppose baby develop scleroderma, shock, DIC, and we know that Acinetobacter is the common organism in our setup, and it will not be sensitive to our first line. In those scenario only we can consider shifting to early. Otherwise, we should wait for at least 24 hours to change to second line.
I think that is a very important message, that any antibiotic will take some time to act, and you should give a due, the duration of some time for this antibiotic to act before shifting on to the second line antibiotic. So what should be the trigger point? The trigger points are two. One, you don't have an appropriate response and you are given this antibiotic for 48 hours. Second, if the baby is deteriorating and the baby is developing serious symptoms, for example, the shock, seizures, or bleeding tendencies, so all severe symptoms. So if your baby is not improving in kind of a static, and you are giving these antibiotics for roughly 48 hours, then you should start investigating why this. Am I dealing with real infection, or am I dealing with is my antibiotics effective? In that case, you look at your microbiology, you look at your acute phase reactants, and if your acute phase reactants are negative at that point, I think you consider alternative non-infectious diagnosis. But in case your acute phase reactants are positive, then you think whether my antibiotic is going in a right, kind of a drug is going in a right dose is going, whether I'm giving it a proper infusion or kind of mode of this drug is appropriate or not, whether there is any extravasation which means that my drug has not gone, one or two doses have not gone. So all those things you check out. The other scenario, this is the first scenario where the baby is not improving. The baby is deteriorating, and you have at least 36 hours have lapsed since the first dose of antibiotics. Then you check all, apart from checking all these things, you can upgrade to the second line antibiotics. So 36 to 48 hours after the institution of antibiotics, the baby is deteriorating. However, what Dr. Joginder was telling, that if the baby is showing extreme symptoms like shock, etc., then and you are on first line antibiotics, then you take a call earlier on to go to the second line antibiotics, at least in presence of extreme symptoms, even earlier than 36 hours. So 36 hours to 48 hours. One answer is 36 to 48 hours on the first line antibiotics before jumping onto the second line antibiotics. But in case of extreme symptoms, you can take call even. Yeah, Dr. Pratima.
Yes, sir. Thank you so much. I think we are done with the questions. I think one or two are there which we can answer in the chat. Maybe that aminoglycoside in the first 48 hours when the urine output is less than 0.5.
Yeah.
They can be given.
They can be given.
And choice of
Only thing is, sorry. They can be given, but only thing is that we should keep in mind that the urine output is physiologically low in the first 24 hours of or there is something like birth asphyxia, or we are dealing with a real GFR, less GFR. So if we are having something, indicating that baby might be at a risk of acute kidney injury, in those circumstances, we should consider the the urine output and try to modify the doses accordingly, rather than blanketing these doses. But there is no contraindication as such to give in the first 24 hours.
Yeah, true, sir. Okay, the first line antibiotics, Ampygenta, they can be used based on the unit policy as already been discussed. The choice of antibiotics for a baby on ventilator. Why can't it be ampicillin and gentamicin? Dr. Subramaniam is asking. I think that can be there if the... The choice of antibiotics, the choice of antibiotics for a baby on ventilator, why can't it be ampicillin and gentamicin? As a first line, maybe he wants to ask.
So yeah, I don't think so. There's a
prophylactic. So we are not giving for every baby on ventilator. We are not starting antibiotics. So the question is not clear. Yeah. Yes.
So I think very important point. There is no role of prophylactic antibiotics at all. No role of prophylactic antibiotics. You give antibiotics only when you suspect that the intubation can be there because of HMD. Intubation can be there because of MAS. Intubation can be because of any other air leak, etc. So if you feel that the baby is sick because of pneumonia, or pneumonia is figuring out into your differential diagnosis, you should start the first line antibiotic. And I don't see any reason to deviate from MP Genta as a first line.
True, sir. Yeah. Thank you very much, all the faculty members. Thank you, Sarjan sir, for such a lovely moderation. I think participants are actually appreciating it on the YouTube also. How common is meningitis in early onset? There are more questions coming, so we can take them up in the Telegram chat only, I guess, sir. Sarjan sir?
Yeah, I think so.
Yes, sir. Yes, I'll put the questions.
So I'm sure there will be many. We can take up into the Telegram.